your previous meetings. Have been subject to conversations in your previous meetings. So obviously what we want to do today is give you an update on those key areas, but happy to take any questions that you may have after the presentation. Just so you're not listening to my voice for a very long time, myself, Matthew Hall and Jack are going to share the presentation and run through all those areas. Would you like us to stop after each section, Joe, or are you happy we run to the end and then pick up questions?
I think it might be easier for people if you stop after each section, so they can remember the questions that related to that section, if that would be all right, Sarah.
Yeah, no, that's fine. And I'm sure you'll keep us on time. So anybody that doesn't know me, I'm Sarah Dugan, Chief Executive of the Health and Care Trust. As I say, thank you for the invitation. If we could just share the slides, that would be really helpful just to help the discussion. So I've mentioned that myself, Matthew and Jack will cover the presentation, and Sue Harris and Winsome Robotham are also joining just as observers in case there's any questions you want to pose to them. So Sue is well known to all of you. I know she joins a number of your meetings. Winsome is our lead for primary care and community mental health. So particularly when we're talking about those areas, if it's appropriate, she'll come in and pick up any issues. I can see the slide deck, but they're on. They're not on slideshow. The ones I can see. I don't know if that is the case for other people. Don't know if it's possible to put them. It just makes them a bit bigger, doesn't it? Oh, thank you. I'll start talking while you load them up. Thank you. So as Joe said, we were asked to cover a number of areas. So we want to just go through the headlines of the Now We're Talking programme, because I think there's some real areas in this programme that you as members could help us with. So we'd really appreciate that. Then go through, sorry, if you can go on to the next slide, thank you. We'll then go on to IAPT Healthy Minds and an update since you last had a presentation last year. We'll talk through neighbourhood mental health teams and particularly some of the work being done with the voluntary and community sector, which I think you might be interested in. And then we'll cover the urgent mental health helpline at the end. And I did just want to note, because it's relevant for all of these areas, that we are now working in shadow form as the Mental Health Collaborative, which means that all of the partners across the system who are interested in and involved in mental health and well-being are part of the conversation and part of the planning processes. So we have the trust, we have local authorities, we have public health colleagues, we have primary care colleagues and VCS, all engaged in the conversations through the Mental Health Collaborative. So if it's appropriate and you want me to, we can pick up on what the collaborative looks like and what it's focusing on a bit later. Thank you. If I could have the next slide. So the Now We're Talking partnership, you're probably well cited on, and you're probably well cited on the orange T-shirts and posters and all of the marketing element that goes with it. But it's a partnership of all of the partners you can see there, the councils, the trust, Community First, Talk Community, and some football association partners as well now. And it's been developed to work across the organisational boundaries and better coordinate all the communications and awareness and engagement about mental health and wellbeing. We've just gone live with this website, so it may not be familiar to you all at the moment, but this website now brings together all of the mental health support and information into one place. So if somebody's reaching out for some support or looking for some support for a family member, this website is now a central point you can go to where the information is all available. So I just wanted to draw your attention to that first, because there's lots of resources on that website that will be helpful. And we had the website prior to the current refresh, and it was accessed by over 75,000 people. But the communication teams across the partners have done a lot of work to refresh the site and make it more comprehensive. So if you get a chance to have a look at that. Thank you. If I could have the next slide. Thank you. So what we've done as part of the marketing and communications around mental health and wellbeing is developed a number of posters. They're really straightforward and easy to access. So if you just focus on the adult one in the middle, you can see there's suggestions, advice and contact numbers if you want to look after yourself, if you're struggling, or if you need urgent support. And what I would say is that any help, I'm conscious that you as Healthwatch members are engaged in a lot of other organisations or community groups. if you can help us at all to get these more publicly available and, you know, cited, that would be really, really helpful. So there's one for adults and 2 for children, depending on age. So we've got a young people's version and a children's version, but I think they're really helpful and accessible. So if you do want any support with this, if you let either myself or Gary Morgan, our communications manager at the trust, know, we can make sure we can get some printed and shared with you, because I think the more these are distributed, the better, to make sure everybody's cited on what the options are and how to access help quickly. So I'm just going to stop on the prevention offer, Joe, before we go on to IAPT, just in case anybody wants to pick up on any of that. Anybody got any comments or questions on that part? No.
I've got one from Sue O.
Yes. Hi, I don't know if you can see or hear me. But...
Hi, Sue, I can, thank you.
Yeah, good. It's technological nightmares. I'm just wondering, recently, the new service of Shout using Woo and Here have been introduced, but they're not actually on the leaflets for children and young people.
Right, they should certainly be on the website where all the information is.
Because I did check probably about 10-12 days ago, and I couldn't find it on there, but that might have been done a refresh. But I just thought it's in, because obviously Couth is wonderful, but it's not 24/7.
No.
And that is on the leaflet, or both the leaflets that you've got there. No, just the one. But that Shout service isn't.
Yeah, and we definitely signed up to Shout. So can you leave that with me, Sue, and we'll make sure that's made more prominent on all of the comms element. Is that all right?
Yep, that's fine, thank you.
Yeah, it's important. And as you say, it's another option. For those that don't know, Shout is more text-based as well. So you, as you say, you've got a different way of reaching out. Thanks, Sue.
I think that's okay for questions, Sarah.
Yeah, okay. Okay, I'm going to ask Matthew to pick up on IAPT if we could move to the next slide.
Sorry, can I just ask a question?
Oh, hi, Bernie.
Hi, sorry, I can't find the reactions or anything on here, so I couldn't put my hand up. I'm really sorry. I was just wondering about Shout. Is that text service 24/7, or is it a sort of daytime service?
Yeah, it's text, and my understanding is it is 24/7, but we will just double check that the details are clearly on the website, if that's all right.
Okay, because I've heard of the Woo and the Here thing as well through other meetings. I don't actually know how to spell Woo in terms of how it's being used, so yeah, it would be really nice to see that.
WOO, I think, and yeah, it's partly Worcestershire and Herefordshire, isn't it? But is it okay if we make those clear, Joe, and pick those up for you, and just make sure that's clearer on the communication?
No, that's great. Thanks very much.
Thank you. Sorry, I had to just put in.
Sarah, there are 2 questions in the chat. One of them is asking if you have information about the Jigsaw support group for carers.
I don't personally, but is that something you think we could include? Because if you know of groups that are out there in the community, obviously some of them may be on Here to Help, the council site as well, which we do direct to via the website. But if you've got any other suggestions, we're very happy if you want to share them, and we'll have a look how they can be incorporated.
Okay, that's from Jigsaw. And then the other question is from Janine D, and they are asking if posters are available in other languages or easy read. And has there been testing on via focus groups with people with LD and or autism?
Yeah, if I may, Joe, I think Gary's on the line, who's led all these developments. Yep. Gary, do you want to say anything just in terms of how we collect all these comments?
Yeah, sorry, I'll just pop something in the chat if that's okay. So if there are any other suggestions for adding to the poster or the website, please let me know. In terms of how the posters were pulled together, yeah, absolutely, through our youth board for the younger people's versions and through our patient panels for the older people's versions. And obviously the Now We're Talking partnership does bring in representatives from a whole, broader range of partners as well, who've all contributed to them. They're going to continually, require developing those. So please, please help us do that through. And I think my details are on the should be on the chat now. So any other suggestions, please let me know.
Thanks Gary. Really welcome everybody's input. For this to be meaningful, we need to signpost to as many options as possible, but also, as you're commenting on Shout, make it really clear what the difference is and the availability and the hours. So we'll pick those issues up. So if we could move to the next slide, I'm going to hand over to Matthew to pick up about IAPT and explain to you where we are with the recovery programme.
Hi there. For those I haven't met, I'm Matthew Hall. I'm the Chief Operating Officer at the Health and Care Trust. I'm responsible for the clinical services across both counties. So IAPT, our Healthy Minds service, just a bit of a recap really. IAPT is the standard NHS-wide talking therapy service for anxiety and depression. It's been running now for around 15 years, and features-wise, it's an evidence-based service, so everything that's offered has to have a proper clinical base. It's manualised, so what we offer is nationally specified, and how we offer it's nationally specified as well. And it's one of the first mental health services to have targets and performance indicators built into it. So it's one of the first that actual patient experience, patient outcomes, the length of time people wait for services actually built in. So we can move on to the next slide. So yeah, the national aim of IAPT services are that everybody who can benefit from a talking therapy for a common mental health problem is offered one. So I mentioned performance indicators just a second ago. So I mean, the performance indicators really start right from referral. So how many people access the service? So locally, our target is that over 21,000 people a year should enter treatment. So that means that probably more than that need to be referred for 21,000 to enter treatment. And then timeliness of response, so how quickly people access. 75% of people need to be assessed within 6 weeks for us to meet our national performance indicator, and 95% within 18 weeks. And working through to the end, once people have gone through treatment and have recovered, 50% of people should achieve what's called recovery, which means they should go from clinically having symptoms of depression or anxiety to actually having recovered fully from those, though a lot more than 50% will actually achieve a meaningful improvement. So a new treatment, and a new target was introduced a couple of years ago, which was that 90% of people had to commence treatment within 90 days. So that was actually quite challenging for us, because we had a lot of our resource geared towards assessment, making sure people could access the service quickly. And when the new target was introduced, that 90% of people had to commence treatment within 90 days, we had to start moving more resource from the front door through to the treatment part of the service. And that coincided with the middle of the pandemic, and also a time when we had fewer trainees joining the IAPT program than we needed, and we had a high vacancy rate as well. So that hit our performance indicators very hard. And if we go on to the new slide, the next slide, I'll show you a little bit about that. So, you know, through 2022, actually, the numbers of people accessing talking therapies in Herefordshire and Worcestershire within the 6-week time frame actually declined and went down and down and down. And on the next slide, you'll see the same for those within 18 weeks as well. And we started an improvement plan in June 2022, really looking at productivity. So how we were doing the assessments, how many patients each practitioner was seeing each week. And we also took all our processes apart as well to try and improve flow, and refreshed our training plans. So who was providing our training, how many trainees were coming into the system, that kind of thing. As a result, we've recovered our performance both at the 6 and 18 week levels now as well. So we're at 91% of people referred now. If you referred this month, you know, there's a 91% chance you'll get seen within 6 weeks, and 98% chance within 18 weeks. That's now back within national target range. There is a bit of a lag in that showing through our our national position, because the performance indicators are actually collected when somebody's discharged from the services. So it'll be till July that we actually start seeing this playing through. If you move on to the next slide as well, we've made a big improvement in how many people are waiting for a service as well. So in April 2022, we had over 4,000 people just waiting in a queue for their first assessment. We're down to in January 731, and that's roughly meeting our referral rate at the moment. So we're in a steady state at the moment, and we're keeping up with the flow of referrals coming towards us. It's important to note, I suppose, that we're maintaining the pace of referrals. So we're able to see everybody who's referred and accepted into treatment, but we're not meeting our access target yet as a system. So more people would have to be referred into the service for us to start meeting that. But at the moment as well, we've also got still significant levels of vacancies. We've got new recruits coming through the training pipeline, but we're still probably 18 months out for being fully recruited. So we've had some underspend, and moving on to the next slide. Some of that underspend we've negotiated within the ICB to release that underspend to PCNs to kind of commission alternative provisions, so local schemes to address common mental health problems. So groups, GPs and PCNs have been able to enhance their local provision by using part of the allocation which we haven't spent on IAP therapists. So the type of things, you know, listed there: additional counselling, cognitive behaviour therapy, counselling for children and young people, coaching sessions, and web-based things like Mood Master courses. This is being evaluated at the moment, quite a complex evaluation because each PCN has got its own separate scheme depending on local need and availability. But this will continue through to, we've got funding secured till March 2024. So PCN, okay, so primary care network. This is a group of GPs who are organised together to look after the health of their local population in collaboration with one another, and they influence the kind of commissioning priorities of the ICB. So the last point around IAPT is around the national rebrand. So at the moment, across England, local IAPT services, and this on the next slide, are known by various different names. So in Herefordshire and Worcestershire, we call our service Healthy Minds. The IAPT branding, so improving access to psychological therapies, and local branding is going completely this April, and all services across England are going to be known as NHS Talking Therapies for anxiety and depression, because this is thought to be a much better descriptor of exactly what the services are and what they do. So I'm happy to pause there for comments and questions, and if there's detailed, I may ask Winston to help me.
Thank you very much. Slide is Gaynor. Do you want to?
First of all, that we are one of the main peer-to-peer support groups, but the GP refers to us, but we don't get any funding anyway, apart from trying to apply for grants. So as you are funding PCNs by the sound of that, then be good to look at how we could get funding. I'm surprised that how your graphs show improvement, considering what people that come to us tell us, and the comments that I get off various things on Facebook, because I've put out messages to ask people their response, and everybody has got, there's not many negative, not many positive responses for Healthy Minds or the what's now rebranded as the emergency mental health helpline.
Do you want to just say who you're from, Jana? Because not
Sorry,
everyone knows.
yes.
We know that you're your organisation, but if you'd just like to say who you're from.
Yeah, sorry, that our charity is called Behind the Smile.
Thanks.
And we support people with poor mental health and those bereaved by suicide. And I previously met with Matthew at the beginning of our charity, and we've had no help, and yet people are referred to us from various GPs. But like I said, all the response is negative. People are waiting. I've heard people waiting still 18 months and things for getting any access. And then when they do get access, it's 6 weeks counselling therapy. So by the time you start with 6 weeks, you sort of like start to open up, and then it's right, your time is up now. We can't, 6 weeks. Yeah.
Thanks, Jana. Yeah. Do you want to come back to that one, Matthew?
Yes. So the funding issue, I'll probably pass on to Jack Wainwright if he's on the screen at the moment. Is Jack here?
Yes, Matthew, I'm here. Thank you. So in terms of the funding for the PCNs, that was delegated, devolved to PCNs to work with local providers to commission the service they felt was most appropriate for their local communities, given the population health information they have. So that there was an approvals process where it came back through the ICB again to check that it met the criteria that we'd set in terms of supporting the reduction of waiting times in Healthy Minds and providing a faster response for patients. But in terms of the selection of the providers, that was left to the PCN's discretion.
Thank you. Was there something else about some other sort of VCS funding that was out there? But that's being organised by the VCS itself, isn't it? I'm not sure.
There are a couple of strands. I think we might come to the second strand in the next bit of the presentation.
Yeah. Okay, thank you.
I have.
VCS are talking with the trust about getting a pot of funding, and the first lot is going to be in the next few months.
Yeah. Okay, thanks, Gaynor. Bernie, I think you were next.
Thank you. Just whilst it's on my mind, obviously people will be aware that I'm the chair of the Autism Partnership Board for Worcestershire, but I also do work with the ICS as an expert by experience as autism champion. So not so much a conflict of interest, but definitely one that I want to put my position out there for, because obviously I'm connected with it. But from a personal experience, I'd like to know some sort of answers to bigger questions, whereas I like the whole idea of the talk therapies and access and everything that's being put in place with all of this. But my concern is that there is no clear path. Now, please correct me if I'm wrong, but as far as I've found, there is no clear path for actually accessing not therapies so much as diagnosis assessments and then the follow-up support for complex cases. So if you visit a GP and you have a very complex case, then you're told to self-refer. Now, if you're particularly severe, self-referral isn't going to be the most positive kind of response to you. Sorry, I've got children at home and all sorts going on around me. So what I'm asking, I suppose, is how does one access things like detailed support and diagnosis processes for bipolar, psychosis, those kinds of things. When you go to a GP, present for that, and then the GP says, go and self-refer to Healthy Minds, which not only is that not suitable for somebody with significant mental health issues, it's also really unhelpful for autistic people. And when I talk about complexities of needs, I don't just mean autism, mental health, I mean ADHD, the demand avoidance, and the various layers that come into that, which then are just continual barriers to accessing the right support. And then of course wait times, that there's just autistic people can't do that on a wider sense.
Thanks, Bernie. Is that you again, Matthew, do you think, or?
Yes, no, I think it probably is. So the talking therapies for anxiety and depression, so it's the IAPT Healthy Mind service, it is for common mental health problems. So more complex needs should be referred to our neighbourhood mental health teams. You know, we have gone through periods, I think, up to recently where people could fall between two stools and referrals could go back and forth. But the Healthy Mind services meet regularly now with the neighbourhood mental health teams to ensure that if somebody's been referred to one service and they're more suitable for another, that they'll just be passed straight across. So more complex needs like bipolar disorder, psychosis, complex emotional needs, or presentations of anxiety and depression that have got a different dimension to them, something like autism, they'll be dealt with through our neighbourhood mental health teams. And that's also where you'll be able to see a psychiatrist and have an actual diagnostic appointment as well.
Thank you, Matthew.
Okay, thank you. Can I just come back in on that then? So I wonder if a bit of comms needs to go out to the PCNs around that, because I'm aware of one particular case where they were just put on social prescribing and hasn't wanted to engage in social prescribing because they're so significantly depressed or unable to access the actual services. That's, you know, even the idea is totally impractical. So maybe comms needs to put something out around that. And actually, even in my role, I wasn't aware that that was the process. So I think wider understanding of that. And I know that this is about IAPT specifically, but I would really like to have a bit more information. Maybe we can connect at another time outside of this about those kind of the monitoring and the performance around that as well. Timeframes, whatever else comes into it.
Thanks, Bernie. Lee, I think you were next.
Just a quick one for Matthew. With the KPIs and the advancements where you're saying you are now with people accessing talking therapies, do I take it that data is used as being a collective data? Because my understanding in Redditch, where I am based, is that it's around 18 months to 2 years to access, as a general rule, talking therapies from Healthy Minds. Is that different in other districts, or so it's just trying to get a clearer idea where you've got that such improved data?
Okay. So every person who goes through talking therapies, all their data is collected all the way throughout their journey, and that has to be reported nationally. So our data that we've got there is an aggregate position. It's also a current position. So we've been working on improving access times for the past 8 months or so. And you know, what I've given you there is what access times are now on average. Obviously, there are some people who may wait longer because they're waiting for a specific type of therapy. So we've still got some long waits in there. We have still got some people who are waiting up to 12 months because they're waiting for a specific therapy. But that number of people who are waiting a very long time is going down and down on a monthly basis as we've improved our productivity in some of our internal processes. So yes, there are some long waits in there. No, that's not the general position.
Thank you very much. David?
I'm really pleased to hear the answer that Matthew's just given us about waits, because it's been absolutely horrendous over the last couple of years, particularly waits for children We've been talking in terms of many months before they were able to get treatment. But I've got something a bit more specific for you. I'm co-chair of the West Midlands Police Advisory Group on Disability, and I wonder how we can link up with the trust so that we're getting better advice on how policemen can handle people with mental health problems. We hear about now that the police station is no longer considered to be a place of safety. So the choice that we have in Worcestershire, as far as I can see, is either to take people to the Elgar unit if they're being disruptive, or to take them to A&E. I don't know. Are there any other alternatives that spring to mind?
It's going to be proportionate to the person's level of need, isn't it? So if somebody's got an immediate crisis, we have got our crisis suite at the Elgar unit, or attendance at ED is an option as well. We've got our 24-hour mental health helpline, which will give access to advice and treatment. And obviously, if the problem's pressing but less urgent, somebody can also contact their GP as well. I'm going to refer you to Sue to how the police, Sue Harris, for how the police can link more effectively with the trust, and she can tell you maybe about some of how that already happens.
Just in the interest of transparency, we've just had a request from the BBC if they can record this meeting. And in the interest of transparency, we've said yes, but I just thought I ought to let you all know. Thank you. Sue,
Thank you. Hi, everybody. Thanks, Matthew. We did touch on earlier, Sarah did, around the Mental Health Collaborative, which is a partnership vehicle for delivery and transformation of services across the 2 counties. The police are very engaged and have been from the outset, from sort of way back in October 2021. We've taken some very specific pathways as they relate to the police through that forum, and we've started to join up some of the training opportunities. So, David, I'm more than happy to link in with you personally if you want more information on how we can make sure we maximise that relationship, if you've got other opportunities that you think we could make more of.
Okay, thank you, Sue. This is going to be very useful because we're actually going through a review at the moment in the police of the way that we're handling everybody. One of the concerns, of course, that we have is if a policeman hasn't been trained in looking after someone with a mental problem, they could be injured during arrest or whatever it might be. So there's obviously a lot of synergy between the trust and the police in how we handle the patients and how we should go forward. But I'll get in touch with you privately after the meeting. Thank you.
Hi, Julia. Sorry, you had a question.
Yeah, thank you. For those of you that don't know, I'm an expert by experience and I work in several different areas and networking. Yes, well, I'm like Dana, I also question those figures that we've been given by Matthew Hall. I've sat on the collaborative board meetings for the last 12 months and I've never seen figures that high. So I'd like to know what's happened so drastically in the last couple of months, and I will hold you.
Nope. You.
Sorry. So I'd like to know what's happened to make those figures go up so high, and I'd also like to hold you accountable for those figures.
Okay. Well, I'm happy to be held account for the figures. So there's a national standard by which we have to measure, collect and report data, and we're adhering to that national standard. There isn't a way I can manipulate the figures to make them seem something that they're not. We've worked with our service providers to work with the teams to improve their productivity. So work on how many assessments they're doing, how long they take on assessment, some of our internal administrative processes as well, you know, and undertaken the kind of normal types of service improvements that you might expect. We've also had some improvements in recruitments. We've got slightly more staff working in the services than we did have. And if you look at the improvements, they're not, you know, they're not sudden. they're gradual. We've been working on this since last summer, and I'm happy to share more details of the program with people as appropriate.
I have copies of all those records already, thank you. Also I'd like to know what is happening at Hillcrest. I've been shouting up for Redditch services for a long time now, and obviously on BBC News last week they have reduced the beds to 10 because of safety and quality reasons. So could you tell me a little bit more about that, please?
We were going to actually leave that till the end, Julia, for over questions, because we were talking about IAP specifically here, but we will bring that in at the end if that's okay, because we've had a question in the chat about that as well.
Yeah, fine, thank you.
Around talking therapies, I've got 2 more questions and then we'll have to move on because we're going to run out of time otherwise. Gaynor, if you could.
I just want to say what's said earlier about people self-referring, and yes, but my son was just given a leaflet to just self-refer. He was on the autistic spectrum. He was still unwell at the time of discharge, but because he just had this leaflet to self-refer, then it was something that he just couldn't cope with, amongst other things, so other reasons, and that's how he ended. Well, that's a fraction of the cause. I'm not saying that is the cause, but I'm just saying that's an example. But then he ended his life. But there are so many people that I see that are just looking at being told that they have to self-refer. And then I spoke to somebody just the other day who was self-referred. She'd waited 18 months to get an appointment. When she eventually got something, she was told, well, what we can offer you is this course online. She said, well, you're assuming that I've got access to the internet and that I've got a computer at home. My phone doesn't take, I've got not enough credit, and the phone is not suitable for these like Zoom things and what have you. And so she was told to go and find somewhere. She said, well, I can go to the library. Oh no, that won't be suitable because it will be sensitive things that people are talking to you about. So there are various restrictions as well, what people are being offered.
Okay.
And like I said earlier, 6 weeks is not enough.
Yeah. Okay, Matthew.
Well, obviously there's a lot in that, Gaynor. Well, the first thing I'd say is that our talk therapies are available. We do use some online resources. We do use remote calls like this, but we offer face-to-face appointments as well, and face-to-face groups. So a lot of it's going to be what's suitable and most convenient for the individual. You mentioned as well then about the number of sessions somebody's offered. We do offer sessions in blocks, and we review somebody's progress at the end of that block of sessions. So if somebody hasn't achieved enough recovery, we may offer more than that. So wouldn't be right to say that anybody only had 6 sessions. So in IAP, people have an average of 12 sessions, but may have more sessions than that as well.
Okay, thank you, Matthew. Simon, I think we're going to make this the last question, if that's all right.
Yeah, thank you, Matthew. You told us the number of people you assess. How many referrals do you actually get from to actually assess is what I'm interested in. So how many get screened out? How many get screened out that don't actually get assessed?
I don't have the numbers with me for that. It's typically between about a third and 50%.
Okay, so what happens to those people who don't get through the assessment, or you You don't assess as needing a service.
So I think we have to remember that IAPT is for mainly anxiety and depression. So if somebody's presenting with a more severe problem or a more complex problem, this isn't going to be the right type of treatment for them. And they'll be referred forward to the neighbourhood mental health team, or they may be passed back to their GP with advice if this isn't going to be the right type of service for them.
Okay. Do you have any idea? I mean, do you have any numbers that fall out of the service? Those people who get referred to you but never turn up for an assessment, for example.
I do, but I don't have those figures with me. But that is something we collect.
Okay, because the other thing that we have had being told about is a letter that you send that they have received, asking them to make an appointment, and typically contains the NHS reference. If you don't follow up this letter, then you won't obviously continue with your referral. Is that a letter that is actually used in the service?
We have used opt-in letters, yes. What often happens with people who are presenting with their GP for common mental health problems, sometimes what they've agreed with their GP isn't quite what they want. Sometimes people feel better, or sometimes people don't engage for other reasons. So we do ask people to opt in so that we can progress their referral in the right way.
So does everybody get asked to opt in?
I don't know at the moment. We have used opt-in letters at times in the past. I'm not sure if we're using an opt-in letter at the moment, but I can check and get back to you.
Okay, we're quite in. Sorry, is that Sarah?
Yeah, I was just going to add, we've been doing a complete review of all the letters because we've had some feedback about some of the wording. So we're just in the process of reviewing all of them, actually. So we can, and if you've got any thoughts or suggestions, Simon, happy to incorporate them.
Well, we have got an interest in opt-in letters because of the impact those can have. And so, yeah, we'd be very interested to know whether you are using them now, and whether, of course, they have had any influence on the numbers of people who have not presented for assessments. It'd be really helpful for us to, because I think it's a national issue, Sarah. It's obviously, and it's not just a mental health issue either. It's a physical health issue, the use of those letters.
Yeah, no, that's fine. We can give you an update on progress, Simon, and some samples of the ones we're using.
Yeah, thanks, Sarah.
Thank you very much. I think we're going to move on to the next bit of the presentation, if that's all right. I'm not sure who's doing it for you, Sarah, but
Matthew was just going to cover community mental health services.
Thank you.
Okay, so since 2020, we've been working on new community health services for adults, a part of a national program as well to revise how community mental health services are provided. The new services are called neighbourhood mental health teams, and they're based on a number of key principles which are in the next slide. So the idea is to make access to specialist mental health services a lot easier. So the principles are there's no threshold. So we'll give advice and signposting irrespective of mental health need, rather than based on severity of presentation. We're using a no wrong door principle. So if you come to us, we'll try and pass you on to something useful, rather than saying, no, this isn't us. Obviously, there'll be exceptions to that. It's got to be for a mental health problem. And we're using a no discharge principle. That means to say that, once you're recovered and you pass back to your GP, if you need to reactivate with mental health services again, then that's a simple process. Well, doesn't require re-referral. A lot of investment's gone into neighbourhood mental health services just to increase what's offered, really. So whereas previously they were services for people with severe mental illness, they're a service now that ranges across presentations from common problems that aren't suitable for IAPT right through to things like psychosis and bipolar disorder. One of the key features is that they'll designed for local needs. So we've got services across the 2 counties. They're ever so slightly different in each PCN area based on how we've agreed with local GPs that services are best offered in that area. They're multidisciplinary teams, so occupational therapists, nurses, social workers, psychologists, voluntary sector staff as well, and with an enhanced role for the voluntary sector working within teams. That's new for the 2 counties as well. As they evolve, and it is an evolving picture, we started in a place a couple of years ago, and we've been working continuously with local populations, service user colleagues, and primary care to work out, what's exactly going to be best for each locality. And that includes developing ARS workers. These are workers that work in GP practices with a mental health specialism and linking in with the neighbourhood mental health teams. So move on to the next slide. So neighbourhood mental health teams are, they kind of slot into the middle there, so core mental health services. So if you access a neighbourhood mental health team, it should allow seamless movement between community offers, so through our voluntary sector partners, helping people access health advisors, social prescribers, and through to specialist services as well. So if somebody comes in through a mental health team and it's clear they're a young person developing psychosis, we'd move them sideways through to the early intervention team. They wouldn't need re-referring. So we move on again. So as I said, working with the voluntary sector as well. So we're working with on-site advocacy, Herefordshire Mind, and South Warwickshire and Worcestershire Mind as well. So it's an integrated offer. So what the voluntary sectors give us is an offer that helps us, address social factors related to mental health and well-being and the wider determinants of health. And we've got access through to psychology services as well. Psychologically informed approaches, group work, and one-to-one offer. Obviously working with Worcestershire Association of Carers for carer support, and we've also commissioned Community First to undertake an evaluation of the effectiveness of neighbourhood mental health services as well. This year, we're planning to increase our voluntary sector capacity, initially in Worcestershire, and we'll be going through a tender exercise to bring on more voluntary sector capacity. We move on to the next slide. So looking at our team locations here, as I said before, we went through, we've developed in 2 phases. So phase 1, we were part of a national pilot of 12 sites starting in October 2020, and we developed the first 7 teams in 5 locations across Herefordshire and 2 in Worcestershire. And we've moved into phase 2 from October 2021 with 5 more teams across the eastern half of Worcestershire. So I've color coded them a little bit there. So the blue teams are ones that are fully recruited, and in phase 1 they're fully recruited and fully functional. So they're delivering everything that's meant to be delivered through the national model. Phase 2, the blue ones are fully recruited, but we're working through developing the offer. Yellow is kind of, we're more than half recruited and we're working on it. And the red teams, we're still in an earlier stage of recruitment. We're having some challenges in recruiting, and it's a slightly more limited offer there. So moving on to some of the challenges on the next slide. So our biggest challenge has been with recruitment. These are new types of mental health services. So we've generally had quite a heavy turnover from staff who were working in the previous types of teams. So what we found is that people who were in traditional community mental health roles, many of those haven't wanted to work in the newer types of teams where they're having to undertake more new assessments and work with a more dynamic caseload. But we're working through that. And as I said, certainly in phase one, all the teams are fully recruited now. The nurses have been the key role that's hardest to recruit to. We've had difficulty in building our nursing capacity. That's due to a national shortage of nurses. So that's made it difficult at times to allocate patients appropriately always to a nurse. Capacity-wise, we've undertaken an analysis of the types, the patient needs of people using neighbourhood mental health teams across Worcestershire, and we found that probably about a third of the people on caseload at the moment will probably benefit more from a voluntary sector offer than they would an NHS offer. That's one of the reasons we're looking to expand our voluntary sector capacity. And about a third probably need more, even more intensive support than they're being offered at the moment. Some of the lower establishment levels in teams like Worcester City and Redditch have impacted some of our functions and how we've been able to deliver them. So especially on the volume of new assessments coming through, and people who've required a moderate level of non-IAP therapy, so people needing complex psychological work. So that's been impacted by our challenges in recruitment in Worcester City and Redditch. But although we have got challenges, we're making progress. I think we're learning and continuously reviewing with our PCN partners, and we're seeing the fruits of this in phase one. We've got larger teams than we ever had before, so we've got more mental health workers working in the community than ever before, and more responsive teams than previously. So the teams are performing well. Referral to assessment is meeting the national standard of 4 weeks or less. The main work for this coming year is to grow and embed our phase 2 teams and to grow our voluntary sector partnerships. Okay, so happy to take questions on that section.
Actually, I thought I might post. I'm sorry for those people who've got their hands up. I was actually, in view of the time, I was just going to postpone the questions on that to the end so that we make sure we get through the whole presentation. Sorry for those people who've got their hands up.
Yeah,
so,
that's fine, Joe. So if Jack can just run through the urgent mental health helpline, but we'll do it fairly at pace, Jack, if possible, so we've got more time for questions.
Yes, no problem. Thank you. So yeah, the final one in our selection today is the 24/7 urgent mental health line, which has been referenced by at least one person today already. If you could pop on to the next slide, please. So the service design was brought into place in February 2020, shortly before as the pandemic was starting. It's an ageless service, and originally out of hours. It's now 24/7 and has been for a couple of years. The calls are answered initially by trained staff employed by the South Warwickshire and Worcestershire Mind. They are trained in the UK mental health triage scale, which is nationally recognised as best practice in this kind of field. But they're co-located with the crisis team in the Elgar unit. So that was from the beginning, and that was to ensure that they were kind of an integrated service. Where there were risks or escalations, that could be dealt with immediately, and support provided as well by the crisis team clinicians to the triage practitioners. They now operate a 2-shift system, 12-hour shifts in line with the crisis team as well, and that's 3 during the day and 2 at night, and that matches the sort of the activity profile as best as possible. So it's 24/7 first point of contact for people with mental health difficulties. It's also been highlighted in terms of suicide prevention forums as well, and it's for patients, professionals, carers, families. Anybody can call. We have now put an I'm going to come to the next slide. Actually, there is a separate professionals line which we put in place, responding to feedback there. But the aim of the service, like like some of the other things we've seen today, is around a no wrong door approach. So you can call this line and you'll be directed to the most appropriate support, and that could be the crisis team, that could be an ambulance, or that could be signposted to sort of voluntary sector organisations in the community. Next slide, please. So these are just the triage categories. This is how the UK mental health triage scale, the sort of the high level categories you can get categorised into. So we'd expect around 5% to be categorised into A and B categories, and that we're in line with sort of national expectations there. And then around 2/3 probably to be categorised into categories E to G, and again we're more or less in line with that. Next slide, please. Thank you. So in terms of the care pathway, the triage practitioners will try to de-escalate the sort of presenting situation immediately on the phone if possible, formulate a safety plan for that individual. And as I say, that could be escalated to the crisis team or ambulance if required, or that could be then following de-escalation signposting to alternative services. That includes safe haven services in both Redditch and Hereford, where they can be signposted to for a longer period of kind of support and safety planning, and if that's required. I think I've mentioned most of this already. In fairness, it's co-located with the team. They can escalate immediately to the crisis team where calls are coming in, and if all the triage practitioners are currently on calls, the crisis team will also step in and take those calls directly as well. So although the triage practitioners are at the front line and triage function, in some instances you will get the crisis clinicians answering the phones directly. The professionals line, which we put in place in response to feedback, goes directly through to the professionals. It circumvents the triage function there. And yeah, I think the bottom point, all calls are now recorded for quality purposes. This wasn't in place until relatively recently, but is now in place. So all calls are recorded, and there is an audit undertaken on a monthly basis as well. So I'm seeing lots of questions pop up. I'll come to them at the end if that's all right. But it's some of the feedback we've had from I think in fairness, a few of the people in this room has been very valuable, but has been quite difficult to pin down at times to specific calls. So we're really hoping that this call recording will allow us to do that and pick up any issues of quality and practice as we go through. Next slide, please. So in response to some of the feedback we had about the line, we have revised the service specifications. This is the newest iteration of the reporting requirements there. They are a middle ground between the current line performance and the integrated urgent care standards, which are the 111 call standards. So obviously expectation of very quick answer of calls through 111 and trying to match that. They're not there yet. There's an expectation that local lines will be required to hit those standards by the end of 23-24. So this is a middle ground as we get on a trajectory towards doing that. So in particular, I just want to pull out really the call audit I've mentioned, answering calls within 1 minute, 95% answer within 1 minute. We're not there yet. At the moment, our performance is around 10 minutes for the mean average for 95%. I think we're at 90% within 5 minutes, but that is an improving position. But then the call abandonment rate is also higher than we'd like it to be at the moment. So it's kind of around 17%, but we believe that's linked to the call waiting time. So as those call waiting times come down, we'd expect the call abandonment rates to come down as well. Next slide, please. And this is an activity snapshot. It doesn't align perfectly to the KPIs I've just shown you because they're just newly revised. We have a very, very detailed dashboard I'm happy to share. It's already been shared in some other public forums. So very happy to share that. But you can see in terms of median call answer times for patients, the median is about around 30-second mark. So although we have a higher mean average, as mentioned, in terms of the median average, it is generally quite responsive. very responsive, in fact. So I think there are some positives here to take from this particularly. But as I say, an improvement picture, I'm very happy to share the detailed dashboard if people want to see that at a later date. And I think really I'll pause there for questions.
Thanks very much, Jack. Are we just going to roll on, Simon, and just finish the entire presentation? Do you think that would be best? And then do the questions at the end?
I've only got one slide, which would be very quick, Joe, if that helps.
Okay.
Left, and then you can take it down.
Well,
yeah.
So, just wanted to raise a few final points. Obviously, this is to give you further information around the concerns you've raised, and we do acknowledge them, and hope you can see there's some plans in place. Just to say that we really welcome ongoing engagement from Healthwatch in all of these conversations about priority areas, your experience and your ideas and creative solutions. And we have also, as one option, thought about the peer review process, which is already underway in the Trust. It's slowed down because of COVID. We do it to look at all of our services, and we'd be really keen if Healthwatch members would like to be part of those. And just to reinforce that the plans and progress and delivery on all of these outcomes are overseen by the Mental Health Collaborative now, which has all the stakeholders on it. So if there are particular issues Healthwatch feel we should look into in more detail, we can do that through the collaborative mechanism. Thank you, Joe. That's the end of the slides.
Thank you very much, Sarah. That's great. So we do have some questions. Oh, I've lost you. Oh, there you are. So my screen has changed. Bernie, I think you had a question.
Thanks. Yeah, there's so many points that I'd like to talk about. Obviously, I won't, and I'll just quickly go through. So first of all, I've had a look at the Neighbourhood Mental Health Service website, with the page on the website, and it's staggering just how much the social prescribing aspect is there in comparison to how little, well, you know, there's so little compared to what we need in terms of those severe psychiatric assessments. So it is as though even when you know where to look, you still have to wade through a lot of mud to get to that destination, whereas it's that destination that people have often been overseeing. You know, it's gone unnoticed for many years. So that's my first point, is that I just think that all the voluntary sector stuff is brilliant, and the fact that a social prescribing is there, but it isn't the be all and end all. And honestly, it feels like that is every single time, or every avenue you go through, that's the first port of call, and that is not always right. And then I'll just highlight that in terms of autism, of course, then there's another barrier. Any barriers you throw at autistic people, you may as well just say goodbye to them straight away. The mental health helpline, that sounds really, really good, actually. Again, I'm not fully aware of what it is, so to see all that was really good. I'm just thinking about the experiential feedback. So we've got all those figures. I'm just wondering at what point we'll see some qualitative stuff coming out of that about people's actual, you know, experiences of the service. And of course, with that triage line and then any follow-up, the understanding around autism and those complex needs. So obviously it comes with different layers of complexity. You might be hit and miss who you get. I know that the Oliver McGowan mandatory training is coming out for healthcare practitioners. Will they be accessing it? And I'm not sure what level that will be at, because there's different tiers of training. So I would suggest that the people dealing with the phone calls will probably need quite a high level, although that's not fully resolved yet. Those are my points. Very fast.
Do you want me to do a very quick response, Joe? Quite a few points there, Bernie, so we might need to pick up them separately with you.
It's absolutely fine. I do expect you to just...
As you know, the Mental Health Collab has already had a conversation with you about the specific element of supporting people who've got autism and or learning disabilities. So we're planning to have a focus on the crisis urgent care helpline at one of our next meetings. I think it might be March. I'd have to just double check, but we could certainly pick that up in the discussion. Just on the social prescribing versus severe balance, I think that's why we've tried to start doing these posters that I mentioned at the beginning. So it's really clear. If you need some, if you're just feeling worried, you might need these options, but actually if you feel you're in crisis or you need urgent help, you need these options. So I think we're trying to make that much clearer on all of the mechanisms we've got on the websites, but we'll have a particular look at the community mental health one and see if we need to do it on there. And just on the Oliver McGowan training, for anybody on the line who doesn't know what that is, that's going to be a mandated training. that's coming for all of our staff. And yes, Bernie, it will apply to all of our staff. We're just mapping staff against the levels that are required, but all of our staff will be required to do at least one level of that training. And as you say, for services that it's more relevant to, they will be expected to do higher levels. So we are just planning how that works and when it can start. But yes, that's built in.
Okay. Thank you, Sarah. I was just going to pose, because there was a question asked very much earlier in the chat, and about, and also Julia raised it, about the reduction in the number of beds at Hillcrest. And I think people would just like you to say, because obviously there'll be a reduction in capacity and what you're doing around that. And I just wondered if that would be all right, because it had cropped up in the, as I say, in the chat.
No, that's fine. I'll just do a brief summary, and then Matthew might want to come in a little bit on the detail of managing the beds in a bit. But as you'll all be aware, and we've mentioned it today a couple of times, actually, we've had a number of challenges around mental health workforce and staffing, and there is a sort of national picture where there is a shortage of mental health qualified nurses in particular. So more are being trained nationally, and we're very keen to retain the staff we've got. But as you'll know, through the pandemic, people have made choices, and we have got a group of staff coming up to retirement age. So we're really focused on how we can fill all our vacancies and recruit to those mental health posts. So that's the first thing. Just in terms of Hillcrest, you'll be aware we had a CQC visit last July. We did a detailed action plan in response to the issues that the CQC had shared with us. That action plan was completed sort of end of August, early September, and we then built in a broader programme of improvement for all of our mental health wards from that time moving forward. And prior to Christmas, the situation seemed to have stabilised, but we've had some additional changes in the staffing during January, which mean the balance between temporary and permanent staff isn't what it needs to be. So we've had to make a temporary decision to reduce the number of beds from 18 to 10 so that we can reset the team, get those permanent posts filled, and then we can start to reopen the beds. So there's a temporary reduction in beds. We will manage those through a number of mechanisms. One is obviously looking at whether we have available beds elsewhere on our acute wards, which we have across Herefordshire and Worcestershire. We're also continuing to look at how people move through the inpatient system, if you like, and how people are discharged at a timely and prompt way so that we don't have any delayed discharges to also help. And we've also looked to secure 5 beds externally from another provider to make sure we can manage with the reduced capacity. But we will be monitoring that on a really close basis, Joe, and we can update regularly. We can update Healthwatch on the progress around that. We just felt the time had come now where the balance of staff wasn't right for 18 patients, so we wanted to make some more significant changes, I suppose, so that we could fill that permanent team with permanent staff and move forward in a positive way. So I hope that helps, covers off those 2 points.
Yeah. Thanks very much, Sarah. David, you had a question? Oh, David Trigger first, sorry.
Okay. A couple of things. First of all, I've just seen on Matthew's map that Evesham is a yellow dot again. That I assume that means that we haven't got the services that you've given to everybody else. But my big point I'd like to make with all this is, can we please make it simple for people to contact you for help? Why can't we have a 123 number instead of 11 digits as a number at the moment? When somebody is desperate, we should make it as easy as we can for them to get in touch with help. And it doesn't matter that you're not able to assess them or give them treatment or whatever. A lot of these are cries for help, and we should make it as easy as we can.
Yeah, thank you, David. Very relevant point. And as some of you will know, we've changed to a free phone number in the last couple of years as well, which is also important so that people aren't constrained from phoning if they're concerned about the phone bill. But we will keep that under review, David. Thank you.
Thank you very much. Are there any other questions? There was one asked in the chat, actually, which I think would be for Jack, if he's still on the call. Yeah. Yep. It was somebody saying that if you ring the crisis helpline for somebody else, there's an issue around that. Is that right?
It might be Matthew might want to come in.
Matthew
on that
rather than Jack. I wasn't sure. Yeah, sorry.
Okay, that's fine. So if you ring the helpline for somebody else and they've given their permission for you to speak on their behalf, then that's not an issue at all. we can give advice and guidance over the line. What I guess would be slightly more challenging is if the person who was being rung about didn't actually want help. Obviously, if they're a mental health crisis and they need assessment under the Mental Health Act, that's a different matter. That can still take place. But we can't accept a general referral if somebody doesn't want to be referred themselves. But as long as you're a carer for somebody and they're aware you're calling and they're happy for you to do that, then that's absolutely fine.
Okay.
Joe, can I just jump in here, because that's not the first time I've heard that, Matthew. It's something that I wouldn't say is regularly mentioned, but has been does get mentioned to us. So I don't know whether you can make sure that message goes back. And as we've previously discussed with Sarah, if we get that information come to us again, we'll try and get the sort of at least the time and date, so that you can actually do something around it. Because often, obviously, patients and carers don't want to be named. But if we can find some information that enables you to actually check that, now you've got your telephone systems in place and what have you, your recording in place. We will follow that up, but it'd be useful, I think, if you could just make the point internally.
Yeah. Okay. I think I've got two more. I mean, is everyone all right still on the call, Sarah, or do you have to rush off at all?
Yeah, no, I think we're okay. I've just realised, Joe, as well, I didn't answer David's other point, if I may. If I just come back to that, which was just about the areas that aren't fully staffed for community mental health trusts. I just wanted to say all areas are being funded for the same range of services, but because we've done it in a phasing, teams are at a different point because it's extra posts and extra funding going in. So we've then got to recruit to those posts. So it's about the pace we can recruit a fully established team. All services need to have the same aspiration and the same outcomes for local people. So yeah, it should be there, David. It's just a time issue. Thank you. Thanks, Joe.
Gaynor, did you have another question?
Oh, yes.
I'm sorry, I can't hear you. Do you need to lean into your microphone? Sorry, it's just.
Sorry, is that any better?
That's better, thanks.
All right, okay. Right. It was me that put in that last point that you mentioned, because I had called in for some of our members over the time that at different occasions, and I've been told that I can't talk about them. So unless they can go and be on the phone themselves and speak to us themselves, even though they've said yes and given permission, they have to talk and explain their situation themselves. I couldn't talk on their behalf or ask any advice for them at all. And the other thing is that all of these numbers of calls are fine, but it's more about the quality of the call that they receive, because it's also that how many of repeat callers are they getting? So it could be the same person calling 5 times in one day or 100 times, but it's about the quality, because I've had people telling us that they get told even at 4 o'clock in the morning, well, just go for a walk, and it's things like, well, we'll call A&E for you, we'll call an ambulance for you, or you go and get yourself up to A&E. And I've had that myself on the calls when I've spoken and tried to get help for somebody, and I was told, well, just take them to A&E because we can't help you.
Okay.
Somebody else have said that I only wanted somebody to listen, but they wouldn't listen. They just wanted me to go up to A&E or get me an ambulance. That's
okay. Thanks, Gaynor. Should we give Matthew a chance to respond to that?
Thanks, Gaynor. I will speak again to our mental health line leads about discussions that they can have with people who are speaking on somebody else's behalf, because obviously there will be limits to confidentiality at times, but as long as somebody's given permission for somebody to speak on their behalf, that's something we can overcome. Your comments about, calling an ambulance or asking somebody to go to the emergency department. I mean, a common type of call we do get is from people who maybe it's serious harm to themselves, or may have actually harmed themselves. And in those cases, obviously, we would give advice to go to ED or may call an ambulance. And at ED as well, of course, we've got our 24-hour mental health liaison team available as well. So it's not just a normal emergency. You're going to the emergency department, but you can actually be seen and assessed there by a mental health professional.
Okay, thanks, Matthew. And I think probably this is the final question, Sue.
Sorry, can I just also say on that as well that you said that the calls go through to a crisis department, like the crisis nurses. We had one of those nurses come to do a talk at our group, and she said, but there's only 2 of them on shift at a time, and they have to go, one of those 2 often have to go out to assess people, leaving just 1 person there. And so there's only 2 available for Herefordshire and Worcestershire. So it's not enough.
Yeah. Okay.
Hello.
Sue Nichols, sorry. Sue Nichols, yeah. Sue Nichols, yeah.
Yeah, I run a support group for relatives and carers looking after family with mental illness. And we recently met with the CQC to express our concerns about the state of mental health services and really how carers are overlooked in majority of these sort of plans. We have speakers come to our meetings, they talk about all these services, but carers do still feel overlooked. Their role is not valued, and I just wanted to ask whether you were aware of the all age carers strategy for 2021 to 2026, because there's lots of promises in there, and I wanted to know whether the Health and Care Trust, what they were going to do to engage with carers and make this policy a reality. Thank you.
I think Sue's answered that one in the chat, Joe. I don't know if you wanted to briefly comment.
Yes, I think she did, didn't she? She said that you're refreshing your carer strategy and that Sue would like to be in contact with you, Sue Nichols.
Yeah, there's some really practical action we're undertaking, Joe, which I think it would be useful to get further feedback on. So Sue, more than happy to make contact with you and meet with you to walk that through.
Okay.
Yeah, I just wanted to get our voice heard by the BBC who are listening in on this.
Okay. Thank you, Sue. And I think I've got a question from Brendan, and then one other question in the chat, and then I'm going to call the meeting to a close, if that's all right, Brendan.
Yes, sorry, I can't find my electronic hand at the moment. Just a couple of things. Number one, it's quite clear that there is confusion around what level of mental ill health the IAPT and Healthy Mind Service provides, and without a doubt, we need more active communications in this one, because I come across quite a number of people with severe mental health issues, and they somehow end up within the Healthy Minds sector, and it isn't appropriate. Secondly, I think, as Bernie said, we need a bit more clarity about the role of the community mental health, the neighbourhood mental health teams, and that's probably yet another comms issue, I don't know. Thirdly, I've been involved, as Sarah knows, and I've spoken to her personally, since I've had concerns about the mental health helpline. Now, I'm becoming assured that situations are improving, and one of them is obviously that the calls are being recorded for training and obviously monitoring purposes. The only thing that I feel, and I've said to Sarah, and nothing that I've yet seen has changed my mind, bearing in mind that I'm very actively involved in the Trust Suicide Prevention Group and various other groups, I'm not of a mind to recommend that to anyone that I come across if it requires a signposting, but I'm open to persuasion, certainly. However, I do feel on the 2 occasions that I phoned the helpline, and I go back, fortunately, 6 months now. First occasion as a carer or a signposter, the response was quite honestly inappropriate, unprofessional, and was not a good thing. And following that, I raised matters internally at the time. The last one, it was a personal issue. No, I wasn't suicidal, but I was experiencing prolonged anxiety, severe panic attack at the time when I phoned. And if that call was being monitored by a mental health professional, God help us, because it was completely inappropriate. There was no, I can't remember what the term is, no wrong door. I would say that I was told categorically after discussing things that I was at the wrong door completely, but without any advice what door to go to. So I think there is a major issue around basic compassion, fundamental communication, an understanding of trauma within the people who are taking the calls. And when I asked, and unfortunately this is over a year ago, when I asked the previous lead of the mental health response team, can you assure me that there is always supervision of the mind, so-called triage people who take the calls? And the answer I got was theoretically. And the theory was that if it was feasible, there would be supervision. And if it isn't feasible, there isn't supervision. So I'm assured if there is supervision, that there is supervision. And finally, before I go, when I tried to make a complaint to the Mind organisation about the experience that myself and I could give times and date, I was told they do not have any complaints procedure. I subsequently received an email which said they did have. I didn't feel it was appropriate at that stage then to complain because I was taking it up internally. And I must say that it was very well received by Sarah, etc. And all I would say is that when you've got 100 calls coming in a day, or calls that are made, if someone is potentially suicidal and they receive
I think you've frozen, Brendan.
Shall I just comment?
Yeah, if you just come back on that, so yeah.
So just a couple of things on the rebranding of IAPT, and Brendan's point's quite right about everyone understanding. Sorry, Brendan, we lost you for a minute, so I was just feeding back and you can perhaps come in. We understand the issues about people knowing where to go and where is appropriate to go, and it's one of the reasons why there's a national rebrand of IAPT, because it's completely acknowledged that everyone is confused about what service it offers, who is appropriate. So that's part of the point of the national rebrand, so that it won't just be local communication. I'm expecting some national and regional communication as well to reinforce some of those messages about that service in particular. And yeah, thank you for your comments on the crisis line. As I mentioned, the Mental Health Collab is going to do a deep dive around the crisis line in the March meeting. So one of the challenges I have around this is there's often quite a bit of hearsay. So if any of you do have any specific examples that you're willing to share, it really helps us inform the discussion and what we need to look at. So please, I'll be grateful if anybody wants to do that, to please get in touch. Probably best through Sue or Jack as conduits, as I know a lot of you have already got their email addresses anyway, but we can pick it up when we get onto the conversation in March again. But we have heard some of this feedback, such as Brendan's explaining, but if anyone else has got any specific examples they want to give us that would help us, that would be really appreciated. Thanks, Joe.
Thanks very much, Sarah. I think I've got a final question. Kerry Rastall put it in the chat, and it was about dual diagnosis. Do you want to ask it yourself, or do you want me to ask it, Kerry?
No, I'm fine to ask it, but my bandwidth is not great today, so you might lose me. Yeah, so I work in the homeless prevention sector in Worcestershire and Herefordshire, and our sort of team's experience with people with complex issues. They might be misusing drugs and alcohol, but also have a mental health need, quite a severe support needs quite often. So our experience in the past has been that we try and link up these individuals with community mental health teams, but then we're told, oh, because they're actively using substances or alcohol, we won't treat them until they are not using. So obviously our staff are then left to emotionally support people into almost rehabilitation when we're not the qualified professionals to do that. We're housing professionals, so the team do try, but they're often left feeling unsupported by statutory provision. So I was just wondering what review, if any, is being undertaken on that front.
I'm not aware of a specific review about dual diagnosis at the moment, unless Jack is. I'm not aware of anything specific, but if you're struggling, Kerry, with some of those connections, it's very much in line with the work of the collaborative. So we can certainly have a separate conversation and work out how we can strengthen that. I think there are quite good working relationships between some of the frontline staff, but as you say, depending on where somebody is in their journey in terms of what they're using, it is sometimes difficult to start a therapeutic treatment in that situation. So there are some exclusion criteria, which I think is partly what you're referring to, isn't it?
It is, but it's on the majority, not the minority in our experience. If somebody's coming in needing homeless prevention support or relief of homelessness support, we run the night shelters as well, so we see it at both ends of the spectrum, really. So it's been an ongoing thing it's probably been since day dot, but you know, in this day and age, it would be good to see some improvement, even some review of that in conjunction with services that work with those people directly.
Kerry, so Sue Harris has put something in the chat saying that they've got a new lead for health and housing that's working through some of the issues. And if you want to contact Sue Harris on susan.harris@nhs.net, she'll put you in contact with her. Okay.
I might know of the person already, actually, because but you never know. We'll link up. Anyway, regardless. Thank you.
Thanks very much. Simon, you wanted to say something, and then we really will wrap up.
Yeah, I just wanted to refer back to Sarah's offer of us joining their peer review. So just to say, Joe, I have had an email from Natalie Willits, Chief Nurse at the Trust, about that. So I'll meet with Natalie, look into what would be involved, bring it back to a board meeting, and then we'll go back to Sarah, because there will obviously be some resource involvement for us. We need to look at what sort of resource we could put into it.
Brilliant, thanks.
When I know what Natalie wants. Okay.
Okay, right. I'm going to wrap the meeting up now. Thank you very much, Sarah and her team, Matthew, Sue, and Jack. Not her team, but ICB anyway. But thank you all very much for coming and doing this presentation. I think it's been really valuable, and hopefully you found it useful as well. Thank you very much.
Thank you so much for inviting us. It's been very helpful. I'm conscious the chat's been moving really fast, Joe. So if there's anything we missed, if you want to email it over, we're more than happy to respond on email if that helps as a starting point.
Brilliant. Thanks very much, Sarah.
Thank you.
Thank you, everyone.